Good afternoon, everybody. Dr. Carla Fry here, and I'm going to talk to you today about acute kidney injury or acute renal injury and renal failure. More oftentimes now we call it kidney injury, so that when it's abbreviated it's AKI instead of ARI, but you'll still hear people using renal, so I'll probably flip back and forth a little bit myself between the two terms. But today, keep in mind that we're talking about acute injury, not about chronic failure or chronic issues of the kidney. So just quickly, I want you to review your kidney anatomy a little bit. I'm not going to spend too much time on this because you already probably know this. You've had anatomy and physiology. But if you don't have a good understanding of the kidney anatomy, I would encourage you to just take a little bit of a look at this so that the lecture will make more sense to you. Some terminology, same thing. I'm not going to go into all of these. I know that you already know oliguria, anuria, polyuria, several different terms to be familiar with. So again, this should be a review for you. And if you find yourself being a little bit rusty with some of these terms, go ahead and look those up again so that this lecture will make more sense as you listen. So to take you back a little ways, some of you more recently than others, having taken nutrition or having studied biochemistry, I'm not going to spend a lot of time on the Krebs cycle, but I put it here to remind you that pretty much everything starts with metabolism. So as we think about what the kidney's role is, we have to recall what the Krebs cycle kind of is and does. And so suffice it to say, we're going to drill down a little bit to the cellular level here, starting metabolism out with what is needed to enter the Krebs cycle. And what we need to enter the Krebs cycle is we need the two carbons. We need the two C's, all right? And so when we go to start metabolism and start the Krebs cycle off in its forever circular pattern that it follows, we're either going to start with carbs, lipids, or proteins. Now, carbs and lipids break down a little bit more readily than do proteins, and we're not going to talk about the carbs and lipids for the purpose of today's lecture. Instead, we're going to skip right straight to proteins. And proteins are really the thing that can kind of give us a lot of fits, if you will, with respect to the kidneys. So, when it comes to metabolism, and we start out with protein that needs to be metabolized. So protein in the digestive system that needs to be metabolized, what happens to it? Well, as you can see in the illustration here, a little bit of a structure of the peptide in the bond there. Don't pay a lot of attention to the bonds. I don't want to give you nightmares about chemistry, but pay attention to the fact that you have an NCC pattern. NCC, NCC, and that pattern just continues to repeat. Now, recalling that what is needed to enter the Krebs cycle is the double carbon, the two carbons, right? Those have to be carved off from this chain. And as they're carved off, what is left over, if you will, is the N, right? And that N forms the NH, or the NH3, which is ammonia. Now, I know that you'll probably recall that ammonia is bad. Ammonia is very toxic for the body, and it is not well tolerated at all. So one of the many functions of the liver is to grab a hold of that ammonia and to change that into a compound that is less toxic. So we've got protein ingested. We've got the body attempting to break that down and start the Krebs cycle. Protein being broken down, pulling apart the two carbons, placing those carbons into the Krebs cycle and leaving the byproduct, if you will, of ammonia, NHC, that being something that is toxic. When it comes to ammonia, what we're going to do with that ammonia is we're going to send that through the liver. And if the liver is doing what it's supposed to do, it is going to take NH3 and it is going to change it to what really looks like a double bonded oxygen with two N's, and those N's become NH2 on either side of that double bond. And this I know sounds a little complex, so just bear with me just for a second. It'll all make sense to you then. But really what is important to know is that this compound that is created, the one that you see over there in the little chemical structure on the left, is far less toxic now. And so that far less toxic compound is able to enter the bloodstream as what we know as blood urea nitrogen, or BUN, right? I know that you oftentimes look at lab values and you see the BUN, but now you have a little bit better understanding of where that BUN is coming from. It's protein broken down by metabolism, starting out with ammonia, ammonia being toxic, entering the liver, liver does its job, compounds that into something that is much less toxic, that being the blood urea nitrogen, or BUN, that we commonly see in the lab values. Now from there, that urea is further handled by the kidney. If everything is functioning as it should, urea is going to head out, having been metabolized. It's going to head out to the kidney by way of the bloodstream to be excreted as urine, right? Now, any number of things can go wrong along the way. And so if you think back to that liver, if there is liver cirrhosis, if there are problems and complications there, then the ammonia may not be broken down into that less toxic compound that is urea. And in fact, when that does happen, oftentimes what we can see is we can end up with issues where the liver tries to compensate in some way, oftentimes by way of the esophagus, and those esophageal vessels will try to figure out a way to help and handle things. We can end up with varices from that, portal hypertension, all kinds of problems. And certainly as ammonia builds up, we can see people, our patients, become more and more confused and completely just totally out of it, because ammonia is so very toxic, and it will cause a patient to be very, very confused and eventually obtunded, and it will precipitate a person's death. So we've got to metabolize that ammonia into urea, and then further the urea has to be moved on through the system by way of the kidney and excreted so that we can maintain normal levels in the body. So blood urea nitrogen, abbreviated as BUN. Don't call it a bun, it's BUN, right? So stick with that. Provided the BUN is excreted in the kidney, the serum BUN will end up staying normal in the body, and we'll go over the norms in just a few minutes. But there are a couple of things that can be a problem. And one of those problems I've already mentioned, and that is that the liver is not actually handling the ammonia as it is supposed to. We may end up seeing major issues with that. So in instances of hepatitis, liver failure, where ammonia is not excreted properly, we all know that that can lead to lots of problems. But we can also see a lot of problems just by virtue of having too much protein. Sometimes in the instance of certain problems such as burns or prolonged use of steroids or GI bleed, where there's bleeding in the gut, that is obviously a protein, that blood is a protein. And then even certain antibiotics, especially tetracycline, you can see that there is too much circulating protein. The BUN is so high that the kidney, even if it is working fairly well, is going to struggle to keep up and to excrete that blood urea nitrogen as it should. So here you see a little bit of a kind of a stylized version, if you will, of the proximal convoluted tubule and the distal convoluted tubules. We're trying to show you a nephron. And when you think about the nephron, they're little factories that are designed to remove and filter toxins, help manage electrolytes, and then, of course, because of those things, they're going to also manage fluid, right? And we'll talk about that in a little while here. You have about 1 million nephrons per kidney. Pretty extraordinary to think about. And if you look at the red portion of the slide, of the photo there, you see that you've got your afferent and efferent pathways, and then you've got Bowman's capsule, and then along the way there you have the proximal convoluted tubule. So what should happen? Well, blood urea nitrogen, along with other things, is going to be coming in to that Bowman's capsule area to be dealt with, right? And what does that mean, to deal with it? Well, think about it this way. Let's just think about it in I guess an analogy would be that you're cleaning out your closet, right? And you're going to try to clean out your closet, but you have no idea really where to start. So you just pull absolutely everything out of your closet, right? You pull it all out of there, and then you check it all out, and then you decide, I'm going to keep this, I'm going to keep this, and I'm going to discard that, and I'm going to discard whatever else, right? So you keep only what you need. So think of this filtration process basically as the same thing, where all of the things that are in the blood are being pulled out, only to decide then these things should remain and other things maybe should go. And so that's really a very oversimplified version, but think about pulling everything out of the closet and then putting back only what you need. And so that means that the stuff we don't need is going to be excreted via the urine. The stuff that we do need is going to be reabsorbed back into the vascular system. So if you look to the proximal convoluted tubule there, you see an example of sodium, chloride, and water, potassium, and urea, all of those things being addressed in that proximal convoluted tubule. And in doing so, we're removing things that don't belong. So some of the blood urea nitrogen is going to be removed, and then other, some of it is actually going to be retained as well. And then it's going to move further on down via the loop of Henle to the distal convoluted tubule, where some other things are addressed, sodium chloride, potassium to some extent, and also water as well. And then ultimately to the collecting duct and down through to the eventual excretion of urine, right? So the way that this works, the way that it should work, is that we should have adequate blood flow. So if you think about that afferent and efferent pathway there, as we have blood flow interfacing with the nephron, the blood flow must be adequate. If the blood flow is inadequate, blood flow means also oxygen. You should think about this in terms of time is tissue, just like everything else is. The longer there's poor blood flow to this area, the more the nephron will suffer, and ultimately the nephron may get into some pretty serious trouble. But also, blood flow impacts the rate at which we're going to see the blood urea nitrogen addressed, right? And that's what's really, really important here. So we'll go to the next slide, and this will show you just another kind of the same thing, but flipped upside down a little bit. The two major influences by which BUN is going to be removed from the body. The first is the glomerular filtration rate, or the GFR. And as nurses, I know you've heard of this before, and you've probably, have some basic understanding of it, but or maybe you did and you've forgotten along the way somewhere. But the GFR is really just the rate at which blood is being sent through the system, right? Via that afferent and efferent arterial. So in this visual up at the top, you've got the afferent and efferent arterial there showing you into the glomerular filtration system. And what we're talking about with the GFR is there adequate blood flow? So think about a person who's hypotensive. You've got somebody who's severely hypotensive. Well, what's going to happen to the afferent arterial if a person is severely hypotensive? They're not going to get enough flow, right? So if they're not getting enough flow, the body is not going to be filtering the blood urea nitrogen as it should, just based on the slower flow of blood, right? In addition to that, when the flow is inadequate, when there's not good blood flow, the speed through which that blood travels through the system may actually be slower. So we don't have enough, and it's also traveling slowly, right? There's not enough volume, and it's traveling slowly. When the blood flow is already impaired, and then the speed through which it travels through the system is slowed considerably, at that point, what's going to happen is there's going to be more time for that blood urea nitrogen to be reabsorbed back into the vascular system. So in two ways, we're not filtering the BUN well because the blood flow isn't good. And in addition to not filtering it well, more BUN is being reabsorbed back into the vascular system than it should. So in summary there, BUN is affected by two things, really both the volume and the speed. Now, you might say, well, why does that matter? Well, guess what? The slower the blood flow and the less blood flow there is, the more the BUN is increasing, right? And as the BUN increases more and more, blood urea nitrogen is higher and higher, the patient is going to be sicker, right? So keeping that in mind, let's think about a person who has, let's say, maybe a GI bleed. Protein, too much protein in the gut, right? Too much protein in the gut. Try to break that protein down in the liver. The liver does as good of a job as it can. There's a lot more circulating blood urea nitrogen than there should be. They've got a GI bleed, so by virtue of having a GI bleed, maybe their blood pressure is lower than it should be, right? So now we have too much protein and we have a little bit of a low blood pressure, meaning we have poor blood flow through the afferent arteriole. Poor blood flow means that we don't filter the BUN as well as we should. Slower speed of travel through the system means that more BUN gets absorbed back into the blood itself. And we have a vicious cycle on our hands, right? Okay, so let's move on. Next to creatinine, because we know that BUN and creatinine are always talked about hand in hand. So where BUN is a protein that has been broken down, creatinine is now a chemical waste product that is generated by virtue of muscle metabolism. So when you think about muscle metabolism, sometimes we have a person who may have a little bit higher creatinine because they're an athlete and they've just run a marathon, and so they may have a little more circulating creatinine. Think about creatinine kinase. They may have a little more circulating creatinine than you normally would because they've done some damage to the muscle. Crushing injuries to the muscle can release an extraordinary amount of creatinine into the system as well. So this is a chemical waste molecule. It's generated by virtue of muscle metabolism, and then it too is going to need to be transported in some way. So as the muscle interfaces with the bloodstream, creatinine is going to be transported by way of the bloodstream, and it is sent to the kidneys to be dealt with. So the kidneys will then filter out most of the creatinine, disposing of that as urine, and they're going to maintain just a small amount, very small amount, right? So we've talked though about how BUN is impacted when we look at the nephron, right? BUN is affected in two different ways by the nephron because it is not only filtered by the nephron, but it is also potentially reabsorbed, especially reabsorbed at a higher rate if the flow through the system is slow and there's more time to reabsorb. Well, creatinine is also filtered. The nephrons filter creatinine as well, and then they secrete it. That's it. They don't reabsorb it. Creatinine is not reabsorbed. So when I've always used to wonder, well, why is BUN, higher proportionately than creatinine? Well, if you think about it this way, with BUN being filtered and reabsorbed, but creatinine only being filtered, that gives you a bit of an answer to that question, right? So it is only influenced by the GFR, the glomerular filtration rate, just by virtue of the volume, not the speed, because there is no problem or no concern with reabsorption. All right, so there are some things that can actually prevent secretion of creatinine, and that should be something that we consider. There are certain medications that can make us hold on to creatinine a little bit more than we normally would. And actually Tagamet is one of those. It's an H2 blocker, and so it can impact the creatinine, and a few other things can, but we won't get too far into that today. All right, so now that you have a little bit of an understanding about BUN and creatinine, let's talk about normal lab values. And here you see at the top right the little drawing with the line and then the two, there's the horizontal and the two perpendicular lines, and then off to the side there, the glucose. This is the best way to express lab values with the Chem 7. And so you might want to just memorize this, because when you're taking down your lab values in the morning, if you're getting a report, this is a really good way to just draw those little boxes and then quickly put in the sodium, potassium, chloride, the bicarb, the BUN, and the creatinine, and then off to the right is the glucose. And you don't have to really write down the sodium, potassium, chloride, bicarb because it's understood that those are your lab values. So you can just put the numbers in there and you'll be speaking the same language as the physicians who are caring for your patients. So your normal BUN should be 7 to 18. Normal creatinine, 0.6 to 1.2. And a normal ratio, and we'll get into that in a few minutes here, but the normal ratio is about 15 to 1. So if I have a BUN of 15, I should have a creatinine of about 1. If I have a BUN of 30, which is elevated, I should have a creatinine of about 2, provided the ratio is holding. And again, we'll talk about that in a few minutes. So this gives you this really simple formula of the serum BUN over the serum creatinine, which will provide you with your ratio. And again, that normal ratio is 15 to 1. So just hold on to that information for a few minutes. Now, let's get into the types of kidney failure, right? We're going to get into the types of kidney failure, and then we're going to come back to some of those concepts that we've just learned about the manner in which BUN and creatinine are secreted. And we're going to come back to the ratio and a little bit about understanding which one of these renal failures or kidney failures our patient is facing. And again, we are focusing on acute kidney failure, not on chronic kidney failure, right? So this is what is known as pre-renal. So think about before the kidney, right? Before the kidney. So in pre-renal scenario, in pre-renal failure, if you will, there are some pretty distinct reasons why this happens. And they really have nothing to do with the kidney itself. The kidney itself is fine, but the blood flow getting to the kidneys is inadequate. So hypovolemia, hypervolemia, which we won't get into because that's a little bit complex, but hypervolemia actually can also cause problems because it can damage the liver. And so that's a whole other matter. But let's talk about hypovolemia, hypotension, which is, again, preventing adequate blood flow, and then issues with the vessels prior to them arriving to the kidney. So if the vessel is stenosed or narrowed, then we're also going to have concerns with not getting enough blood flow to those nephrons, right? So those are some of the reasons why we would see a pre-renal failure, right? In the instance of pre-renal kidney failure or pre-renal failure, I guess I can't use the kidney and the renal at the same time. This is actually the most common cause of kidney injury and kidney failure, and it is the result of it, regardless of which one of these things is happening, is that the GFR is going to be decreased, and because the GFR is decreased, we're going to see increased reabsorption of the BUN. We're going to see not enough BUN being secreted out of the body, and so the BUN is going to rise. The creatinine, abbreviated CR, is also going to rise because it is also impacted by the GFR. So we have a BUN and creatinine that are rising. We have a patient who is not making adequate urine output. They're at 30 an hour, maybe, if we're lucky, but they're probably going to drop to less than 30 mLs per hour of urine in the Foley catheter, right? And they're going to begin to show us signs of renal failure. So that's pre-renal. Nothing wrong with the kidney. Everything wrong with the blood flow getting to the kidney. And then renal, or some people will call it intrarenal, is another type of failure. And in this instance, the blood flow is probably just fine, although it might not be, but the blood flow could be fine, but there's damage to the kidney itself. This is structural damage. So there may be an inflammatory situation like glomerulonephritis that is causing inflammation that is sufficient to damage those tiny little factories that are supposed to be helping for us to secrete the waste out of the body, right? Helping to manage not only just the waste, but also other things like electrolytes, etc. And we'll talk about those down the road too. But glomerulonephritis is a prime example of an intrarenal problem or damage to the kidney structure itself. We can also see ATN or acute tubular necrosis as a reason why there is damage to the kidney structures. Well, this one's interesting because if you think about pre-renal, when I talked to you about pre-renal, I said, well, there's not enough blood flow getting to the kidney. If there's not enough blood flow getting to the kidney, that means there's not enough oxygen, which means the kidney is getting ischemic. Well, how long do you think it's going to take for a kidney not to get enough oxygen for it to start to die? Again, we keep on preaching the same thing all through this course, is that time is tissue. You have to get oxygen restored to that vital organ, and if you don't, the organ will begin to die. And so sometimes we see ATN occur as a result of pre-renal failure. So now we don't just have a pre-renal problem, we have a pre-renal problem and we have an intra-renal problem. So in this instance now, we can have both and things are getting worse and worse. But let's come back to just a pure intra-renal or renal problem like glomerulonephritis, where we've just got an inflammation that's causing problems. When this happens, we don't have a blood flow problem, right? Glomerulonephritis is just a kidney structure problem, and so the blood flow is totally fine. So with the blood flow being fine, that means the GFR is good. BUN isn't having to worry about the GFR. BUN may be impacted slightly by virtue of the structural problems, but it is not having a problem being filtered, right? So in this instance, the BUN and creatinine may also both rise, but if they do so, they're going to rise basically in tandem. They're going to rise together. So if that's the case, we're going to see a normal BUN to creatinine ratio, right? So, and that's important, because if we come back here, we'll try to go back a little bit. Let's see here. Oh, I guess we won't be able to go back, but I'll show you here in a few minutes. But if we go back to pre-renal, in pre-renal situation, the BUN and creatinine ratio are not normal. In fact, typically it's going to be more like 20-to-1, right? So that's an important distinction, and one of those little clues that you can get in the lab values that can help you to know that there may actually be a renal problem as opposed to a pre-renal problem. Now, post-renal, this one is a little more rare. We do see it. We see it more oftentimes with situations like with tumors. Looks like I have a misspelling there. Sorry about that. We see it with tumors, and we also see it with prostate problems. So you may see post-renal issues a little more often in the male population. And there are other reasons why. Renal calculi, kidney stones can cause it, and blocked catheters can even cause this in a worst case scenario. So this is a consequence of a urinary tract obstruction, which is very different. It's not a matter of not getting good oxygen. It's not a matter of having damaged nephrons or inflammation inside of the kidney, but this is a problem after the kidney where there is a urinary tract obstruction preventing urine from going out of the body. And so, in fact, if that happens, you can begin to experience a backup, if you will, of urine. And when that happens, we will also begin to see problems. So here you see an example of the urinary collection system, the right kidney, and then the wall, and those little calculi over off to the right. The size of those things is crazy. Those are stones. Those are kidney stones, and they can easily block a ureter. And when they block a ureter, of course, there's going to be no forward flow. If there's no forward flow, we're going to begin to see damage. And sooner or later, because of the fact that there is no forward flow in a post-renal situation, we will also end up with intra-renal problems. And to make matters even worse, if we have intra-renal problems, sooner or later, we may end up with pre-renal, and the whole kidney system is kind of jeopardized. So this is just a summary slide of three different types of acute renal failure. Pre-renal being a sudden or severe drop in blood pressure where there's not enough blood flow to the kidneys. Intra-renal being direct damage to the kidneys by virtue of some inflammation or toxins, infection, and again, it can be that there's reduced blood supply that causes ATN. And then post-renal, where there's an obstruction, and again, remember, we're talking about acute kidney failure, so a sudden obstruction that keeps or prevents urine flow from happening, and that can be from an enlarged prostate. And you might say to me, well, why would an enlarged prostate be an acute problem? And what I would say is that it's not. A prostate enlarges over time. It definitely takes time to get enlarged to the point that it's going to cause obstruction, but there are many medications out there that will cause problems with the prostate. So if you have someone who already has an enlarged prostate, for example, they should use common cold medications very, very sparingly, because even things like regular over-the-counter medications can cause the prostate to become further enlarged and make it so that that person cannot pee, and then you've got a post-renal scenario on your hands. All right, so let's talk a little bit then, now that we've got the pre-renal, intra-renal, and post-renal types of failure a little bit in hand. Let's talk about some lab values that are commonly seen so that you can understand these and you can make sure that you can speak the language when you get these lab values back. So the first thing is urine osmolarity or osmolality. Urine osmolality is a test that measures the concentration of the particles in urine, and the normal is about 50 to 1200 millimoles per kilogram. All right, and so urine osmolality is going to be affected by many, many things, but in particular, it's going to be affected and increased when a person is hypovolemic. So in a pre-renal scenario, we're going to see issues, very specific issues with urine osmolarity where it becomes increased, right? And we'll talk a little bit more about that here in just a minute too. Urine osmolarity, or that concentration, is decreased in diabetes. And that stands to reason. You all know that with diabetes, we have polyuria and polydipsia. People pee a lot, but they're not peeing out fluid that is concentrated. They're peeing out very much just peeing out water, right? It's going to be it's very dilute. And so by nature, then that osmolality is going to be decreased. Then there's urine specific gravity. And a specific gravity is really just measuring the density of the urine. And that's comparing it against the density of distilled water at a certain temperature. So when we check the specific gravity, we're looking to see how dense is the urine. And the normal for a specific gravity is 1.016 to 1.022. So that's our urine specific gravity. Then urine sediment. In normal urine, there shouldn't be any sediment. Sediment typically is dead cells, and we shouldn't really be seeing dead cells, and we shouldn't be seeing blood cells, and we shouldn't see crystals and calcium and cholesterol, and we certainly don't want to see bacteria. But if there is sediment in the urine, if it's positive, then that's an indication that perhaps something is wrong, and depending on the type of sediment that it is, that could help point a little bit more to what exactly it is that's going on. Then there's this little calculation that we can do called the fractional excretion of sodium, or the FENA, FENA. Now, we don't really see this all that often, but if you work with somebody in nephrology, you're going to see it all the time, because what they're doing is they're trying to take and get a little bit more specific or accurate assessment of kidney function than just urine sodium. So in this instance, if we have somebody who's oliguric, in other words, they're not making enough urine, and we suspect that they have acute kidney injury, but we can't tell quite why, we can use the FENA to help us to glean a little bit more information, right? Hypovolemic patients tend to have a higher urine sodium. They're going to have that higher osmolality, and so we know that already. But with the FENA, we just get just a little bit more information. Now this test is only good if they're not on diuretics and they don't have chronic kidney disease and they don't have an obstruction, because otherwise it's going to be invalidated, right? So we would only use it in the case of what we think is an oliguric acute kidney situation, primarily in a pre-renal state. Using the urine concentration alone isn't quite as accurate, and so that is really just because the ADH, the antidiuretic hormone, and the way that it handles water, and we won't go any further into that for today. All right, so the fractional excretion of sodium, or the FENA, and this is how you measure it. It's really pretty simple. It's the urine sodium times the creatinine over the serum sodium times the creatinine times the creatinine. So it's serum times urine on the bottom, urine times serum on the top. You can see the equation there. Clearly, I'm acting dyslexic reading it to you. It comes out to be what your FENA is. And this helps us to try to decide whether we have tubular necrosis, which is an intrarenal problem, or if we have a pre-renal type of a scenario going on. In the case of the FENA, when we get our calculation done, it's going to be expressed as a percentage. And if we see less than 1%, that suggests that we have a pre-renal problem. And an FENA that is greater than 2% suggests an intrarenal problem like acute tubular necrosis. Now, again, remember, and oftentimes acute tubular necrosis, that is that intrarenal problem, is actually coming from a prolonged period of pre-renal issues. So we've got an ischemic kidney that is further damaged. Now we've got damage to the structure of the kidney itself, not just having a problem with a quick rise in the elevated BUN and creatinine. So it's extremely important that we don't let a pre-renal scenario go on for a long period of time. If we do, and we have an FENA that is greater than 2%, suggesting that we may have ATN, this now means that we have probably some damage to the kidney that's going to be a little harder to overcome. All right, so this is going to just be a little bit of a summary of the pre-renal and the intrarenal. We won't bother as much with the post-renal at this point. We've talked about that already. But pre-renal is not enough blood flow, so that means that the body is going to hold on to sodium, right? So if I don't have enough blood flow, yes, my BUN and creatinine are rising, but I also need to hold on to sodium, because we all know that what sodium is going to do is sodium is going to help us to hold water. So we're going to retain sodium, so the serum sodium is going to begin to rise as well. And as the serum sodium begins to rise, fluid will follow, and that means that urine output is going to be greatly reduced. What urine does come out is going to be very concentrated, right? So there's not going to be hardly any sodium in the urine. It's going to be a low urine sodium, but a high serum sodium, and that can be dangerous. We all know that already. So we're going to have a high osmolality, and that concentrated urine is going to be generally around 500 or greater. The urine-specific gravity is going to start to bump a little bit. It's going to be a little bit elevated. And then as far as sediment goes, there really shouldn't be any sediment in the urine with a pre-renal scenario, because this is not a situation where there is damage to the kidney structure, right? So we should not see sediment. The BUN is going to be increased for both of the reasons we talked about, because of the GFR being decreased and because of having more time for increased absorption back into the vascular system. And then the creatinine is going to be increased because of the decrease in GFR. So for one reason, so the BUN is going to go up twofold to every 1 for the creatinine, so our ratio is going to be off. It's not going to be 15 to 1, it might be more like 20 to 1 BUN to creatinine. That's your pre-renal. And then with renal or intrarenal, the damage to the kidney structure that's going to impair filtration, urine output might actually be increased. You might say, well, why would that be? Well, because the cells are damaged. And if the cells are damaged, they're not working like they should, they just might let things just kind of fly on through there. So if that's the case, things aren't being filtered properly, the urine sodium actually is going to become higher. So when urine sodium becomes higher, what do you think happens to serum sodium? It's going to be lower. And with a low serum sodium, we can see seizures. We can see all kinds of dangerous things. And so if we have damage to the kidney structure itself, that can become very, very dangerous to a person. They can end up with seizures. They can end up with cardiac arrhythmias, all sorts of other issues. Now, as urine is kind of pouring through a damaged kidney, the urine-specific gravity is going to be low. The BUN and creatinine ratio is going to stay constant. It's going to be at that 15 to 1 or even a little bit less. But we're going to start to see urine sediment, because these are dead cells now. And dead cells are being generated because there's damage to the structure. And the FENA is going to be greater than 2%. And it's greater than 2% because the urine sodium is high. And so just by virtue of plugging in that number, if you go back to the slide where we have the calculation there, you're going to see that the FENA is going to raise. So a high urine sodium is already giving us a little bit of a picture that we probably have an intrarenal problem. And if we have an intrarenal problem and we have a really good, obvious set of circumstances to point to, great. But if there's no other reason why the kidney itself should be damaged, you have to begin to think about ATN as a result of the pre-renal failure. Hope that makes sense. Okay, so let's talk a little bit about the role of the nurse. So the role of the nurse in this is the first and foremost thing is to prevent acute kidney failure. You may say, well, Dr. how can I prevent failure? How can I do that? Well, I'll tell you what. When you have a patient who hits the door to the emergency department or is on the medical surgical unit or any place else in any other setting who experiences a drop in blood pressure, is hypovolemic, dehydrated, right? And you don't treat that quickly and you let that blood pressure stay low, time is tissue. Time is tissue everywhere. A low blood pressure is going to translate to a lower cardiac output, is going to translate to a lower kidney output, right? It's going to perhaps cause issues with a person not being as alert and oriented as they should be. Time is tissue. So we first and foremost want to say, you know what, we've got to protect the kidneys. And to protect the kidneys means they have to have adequate blood flow and oxygen. Restore that blood pressure to normal as quickly as you possibly can. Keep the person hydrated, and that prevention is absolutely key. Now, you say, well, how do I know that the kidneys are being damaged? They're kind of silent. They don't tell me anything. And they really do, but they don't tell you something right away. You're only going to know that the kidneys are starting to struggle when you get a decrease in urine output. That's going to be your first real sign. And so if you don't have a Foley catheter in, if your patient is voiding on their own, or perhaps they're incontinent and you can't measure their urine output, then that's going to be difficult. Right? So if you've got somebody who's pretty sick, then, even though I know we're careful about not putting in a lot of Foley catheters, you really do need to get a good handle on how much urine output they're making. By the time the kidneys start to slow the production of urine and the patient gets oliguric, the kidneys have already taken a hit. They're already telling you, I don't have enough oxygen to do what I need to do. There's already a pre-renal situation beginning to unfold. So the best thing to do is to prevent that, right? All right. So another thing to point out, and we'll talk about this more when we get to our multi-organ failure, is that you do have a little bit of a warning before a person has damage to the kidney, and that is the gut. In the cascade of organs that fall when a patient is hypotensive or experiencing shock or they're severely dehydrated, the first thing that's going to be a problem is the gut. And so if the first thing that's a problem is the gut, then we need to think very, very carefully about that, because remember that the gut has many different functions, including that of the liver. So if I've got an ischemic gut because I don't have a high enough blood pressure, that ischemic gut means that my liver may not be doing what it's supposed to do. And remember back to the beginning of the lecture when we said that part of the function of the liver is to process ammonia and turn it into urea. Well, if my liver's not working correctly because it's already ischemic, then it maybe isn't going to process that ammonia properly. Ammonia level begins to rise. If the ammonia level begins to rise, then we already know that we're going to have problems, and that's even before everything gets to the kidneys. And perhaps the kidneys have a much higher burden of trying to process protein. And they definitely have a higher burden of trying to process creatinine, which is the byproduct of muscle damage, if the person is severely ischemic and they're getting into a catabolic state. So you can see where this could be a very, very slippery slope, right? So your role, your biggest role, if you're going to be a critical care nurse, is to think 2 or 3 or 5 steps ahead of everything and to recognize the fact that kidney failure is you're already 2 systems in. You already have an ischemic gut. By the time the kidney is showing you signs of problems, the gut is already ischemic. So now you have 2 organs. With 2 organs in dysfunction, our mortality rate is going to jump to at least 20%, right? So stay on top of lab values. If you have somebody who's sick and they're starting to show you that they're having problems with blood pressure, they're really not doing so well, they have a fever, they're tachycardic, you got to monitor their I&O very carefully. Hourly intake and output, so that you know that if that urine output drops below 30, that you get in touch with the physician and you start jumping on that and being proactive with it. That doesn't necessarily mean fluids either. Just because the urine output is dropping doesn't mean that they're dehydrated. So we need to try to get to the bottom of it and see, are they dehydrated? If they are and it's pre-renal, that's great. Then just, flood them with fluids and, get the blood pressure back up and things should start to normalize. But maybe we have a kidney problem that is internal, inside the kidney, intrarenal, or maybe there's an obstruction. And if there's an obstruction, then there's a whole bunch of urine sitting in the bladder, perhaps, that can't get out, right? So in that case, you would need to do a scan of the bladder quickly at the bedside to see if, in fact, maybe the bladder is totally full of urine and it's not really a situation of oliguria at all, right? So the role of the nurse: recognition, prevention, proactive communication, staying on top of labs, staying on top of that I&O, maintaining very strict sterile technique if you're inserting a Foley, and then certainly keeping the Foley catheter only as long as you absolutely have to. All right, so in the process of evaluating our patients, we're going to be, we talked about this, looking at urine output. You're going to look at that urinalysis, see what's the specific gravity. Even the specific gravity and the presence or absence of sediment is giving you a clue as to what's going on with your patient, and now you know this. Using a bladder scanner if we suspect that there may be a post-renal situation. Finding out, is there a history? Does the person have a history of stones? They have a history of taking certain medications? Are some of those medications perhaps having a negative influence on the renal system? And then doing a full clinical examination, looking for the presence or absence of edema, looking for orthostatic hypotension. All of these types of things will come into play. So for treatment considerations, the first thing we need to really try to do is identify what's the underlying cause of this acute failure. And then, if there is acute kidney failure, is it already sufficient that we really need to start a patient on dialysis? And you might say, well, how do I know if I should start them on dialysis? So this is something that requires, a great deal of thought, but it also requires prompt thought and action. We can't wait and wait and wait to start somebody on dialysis or renal replacement therapy. The longer we wait, we now know that pre-renal is going to turn to intrarenal. So we're going to have acute tubular necrosis on our hands if we wait too long with an ischemic kidney. So if we see hyperkalemia, where the potassium is elevated, that's a sign that we may have a problem, that potassium is not being excreted as it should be. Acidosis, and I know you had another lecture on acidosis and alkalosis, but in the presence of acidosis with a person who's oliguric, you should begin to get worried that not only is my kidney not doing a good job at managing waste and fluid, but it's also beginning to fail from an acid-base balance. So we have acid-base problems, we have electrolyte problems, we have fluid problems, and we have filtering problems with toxins. All right? So our nursing considerations, when we're getting close to the point where we think we may have to perhaps put a patient on dialysis, obviously hourly I&O, very, very careful intake and output. And many times a physician will give you a protocol and they'll ask you to replace ml for ml, exactly how much is out in the urine, and only as much as is out in the urine. Only use IV fluids judiciously. In other words, we don't want the fluids running wide open because we may be doing more harm than good. Managing that blood pressure, which I don't have on the list there, but that's of paramount importance. Sometimes fluid restriction, but fluid restriction is controversial because as soon as you restrict somebody's fluids, the only thing they want is fluids. So that can actually be a little bit counterproductive. Preparing for surgical intervention if we have a situation on our hands where they're going to need to have an obstruction addressed. Making sure that adequate protein is given. If adequate protein is not given and you begin to see a person with edema, they can really start to third space their fluids. Preventing complications. So we don't want too much protein. Let me go back to that. Not too much protein because the kidney is already having a problem, and remember the kidney has to handle protein, right? So not too much protein, but enough, right? So you need a dietitian there, right? And then preventing complications like DVTs and decubitus and arrhythmias. As potassium begins to rise, people are certainly prone to ventricular tachycardia and ventricular fibrillation. So we want to make sure that we're watching very carefully what that potassium is doing. I won't say too much about medications, except to say that the kidneys are responsible for the metabolism of vitamin D and for insulin, and they are responsible for excreting many, many water-soluble drugs. So what stands to reason here is that depending on what medications your patient is on, we need to make adjustments to the doses. If the kidneys aren't working and these are water-soluble drugs, we must address what the dosage is. If you don't address the dosage, you run the risk of a person developing toxic high levels of whatever that medication is. This is where you got to know your pharmacology. If you've got somebody in acute kidney injury or acute failure, you've got to talk with the doctor and say, should we stop this drug? Should we withhold it for now? Should we change the dose, or do we continue it? So these all need to be evaluated sooner rather than later, so you don't end up with toxicity for certain medications. Now recall that the kidneys are doing several things: managing waste, managing fluids, managing acid base, and managing electrolytes. And there are many electrolytes to talk about, but for the sake of time, I'm going to talk about one that's really, really important, and that is potassium. So emergent management of hyperkalemia. Remember the normal for potassium is 3.5 to 5.3. In kidney failure, it's nothing to see those levels go sky high into the high 5s and even the low 6s. And when they do, your patient is at very, very severe risk for developing lethal arrhythmias. But the first thing they're going to do is develop peaked T waves. And if you recall from the cardiac lecture, it showed you a picture of what a peaked T wave is. It's not the same as ST elevation. It is a T wave that originates on the isoelectric point and goes sky high. Usually it's narrow and then back down. And that peaked T is giving you a little bit of a glimpse into the fact that there very well might be a hyperkalemic situation. Maybe even before you get your labs back, you see peak T waves. So we have EKG changes. We have a high serum potassium level. We got to do something. And the typical regimen, and this is all administered IV, the typical regimen to emergently decrease circulating potassium is insulin, bicarb, and D50. Insulin, bicarb, and D50. It's a little cocktail. And typically the way, and this slide gives you a little bit more information than you even need, most of the time we'll give like 10 units of regular insulin IV, a half of an amp of sodium bicarb IV, and a half of an amp of D50 IV. Insulin, D50, and sodium bicarb. These are the things that are used to very emergently help to bind and reduce potassium that is too high. Now, there are other ways to do it, but that's the IV method. That's the quick way if we've got somebody who is already experiencing issues and we're super concerned that we need to do something about it. And so in this scenario with this algorithm is, do they have EKG changes or do they not? What do you do? And there are many different decision points, but just knowing emergent treatment is insulin, D50, and bicarb is good. All right, just a quick aside here on nephrotoxicity. If you have to use contrast, if you have a patient who has to have IV contrast, we want to be very, very careful about that because it can definitely cause damage to the kidneys. The best thing to do is to make sure that you really flush those kidneys with adequate fluids. If the patient can take oral fluids, great. IV fluids, if they aren't able to take oral fluids. And then the use of N-acetylcysteine, which is just really an antioxidant, can afford some protection. So again, staying on top of these types of things. If you know your patient's already got some kidney insufficiency and they have to go to the cath lab and they're going to have contrast, it's something that you may want to make sure you point out to the physician if they don't already know, hey, they've got some chronic kidney insufficiency already. What about using this very safe, inexpensive treatment to prevent and to protect the kidneys. Now, just a little bit about vascular access. If we're going to have to do dialysis, a double lumen catheter is inserted typically into a large vein. We like to use the jugular or the subclavian. Subclavian is a little more dangerous because of potential for pneumo. And the femoral site is really dangerous because of infection. The femoral site should just really be considered kind of a dirty site, if you will, and it should only be used when we have to. Strict sterile technique needs to be used for insertion and for dressing changes. Keep it clean and dry at all times, and this catheter should be marked very carefully so that it is only used for dialysis. Sometimes dialysis catheters have a little bit of indwelling heparin to help keep them from clotting, and if you went along and you decided, oh, I need to use this access, and you didn't aspirate back first, you can be injecting indwelling heparin right directly into the patient. So this is not done all that often now as much as it used to be, but it can be done. So we want to make sure that these are marked not to use, and only the dialysis nurse should be accessing the dialysis catheters, or somebody who's trained in critical care and has a thorough understanding of what to do with them. So dialysis use only, right? This is going to be used for hemodialysis or for continuous dialysis that we're going to talk about here in a minute. So renal replacement therapy. Why would we use renal replacement therapy? Well, you guys all already probably have some familiarity with hemodialysis, which is, typically done as an outpatient or even as an inpatient, maybe just routinely, 2-3 days a week, designed to eliminate waste, maintain fluid balance, maintain electrolyte balance, acid-base balance, all those things. But in the case of a person who is acutely and critically ill, they may well have a problem tolerating hemodialysis because there's a good amount of blood outside of the body at any given time. So if they're already hypotensive, they're already critically ill, we're already worried about the kidneys not having enough circulating volume to function properly, the last thing we want to do is try to do a hemodialysis where we take off maybe several liters of fluid in one sitting. So instead, we'll use a renal replacement therapy that is different in that it is continuous and it is slow. So we slowly remove or we slowly ultrafiltrate as opposed to doing a 2-hour or 3-hour session in dialysis, the kind of dialysis that you're familiar with. And we're not going to talk too much about peritoneal dialysis today because that's less of an acute care issue, but we're going to talk more about continuous renal replacement therapy or CRRT. Now, I'm not going to get too far in depth in this because it's complicated, and usually anybody who's going to care for patients using CRRT is going to have specialized training. But I do want you to have at least the basics so that you can understand and speak the language, again, as you move a little bit closer to maybe perhaps a career eventually in critical care. We have slow continuous ultrafiltration, or SCUF. We have continuous veno-venous hemofiltration, CVVH. Continuous veno-venous hemodialysis, CVVHD. And then continuous veno-venous hemodiafiltration. I can never say that one, CVVHDF. So SCUF, slow continuous ultrafiltration. Think about SCUF as just really doing only one thing, and that is it's just removing excess fluid from the bloodstream. So maybe we have somebody who's very, very severely fluid overloaded. They're so severely fluid overloaded that we've got to remove some excess fluid from the bloodstream. Perhaps this person's showing us some pulmonary edema. So slowly removing and ultrafiltrating, removing that fluid from the bloodstream is not requiring that we do anything too particularly special. Blood's just going to be out from the access port, and then we're going to remove a certain amount of fluid, whatever's prescribed, and then the blood is returned to the body. We're just doing this to really the indication is really just fluid overload, and that's SCUF. No dialysate is used, no replacement of electrolytes, nothing. Then next is the continuous veno-venous hemofiltration, or CVVH. In this instance, we're removing a little bit larger volume of fluid. We may actually do some replacement fluid, particularly if we're trying to manage electrolytes. So perhaps we're going to remove a lot of fluid out of the body that is pretty concentrated in higher maybe potassium, for example. And then as we replace fluid, we're going to replace fluid with something that is obviously not high in potassium. We're not using dialysate, so we're not trying to really pull anything in particular. We're just managing larger molecules, and we're managing fluid volume and just replacing then with a fluid that is a little more electrolyte balanced, if you will. CVVHD, now we're removing fluid by diffusion using dialysate. So in this case, we're trying to manage very specific things. Maybe the person's sodium is high, or the potassium is high, or phosphorus is. So whatever electrolyte we're trying to go after, we use a certain type of dialysate, and that dialysate is going to help by virtue of diffusion to remove fluid and to help us manage the electrolytes a little bit better. We're not using replacement fluid. We're not doing that. We're really just kind of think about this as a little bit more of cleaning. This is a very effective method by which to remove medium-sized molecules. And again, I'm just giving you a very, very broad overview. There's a lot more to go into, but we're just trying to do the broad strokes today. And then in CVVHDF, in this instance, we're going to use replacement fluid and dialysate. So we're doing things in two different ways now. We're using diffusion, but we're also using convection, if you will, for solute removal. So this is really the most complicated of all of the different CRRTs. We're now using a fluid replacement system and a dialysate, and we can really combine all of those therapies into one, where we can manage waste product, we can manage fluid balance, acid-base balance, and electrolytes. So here's a summary of the different modalities. Again, this is just a broad picture of CRRT. The primary indication for CRRT being that we have somebody who is very critically ill and there's no way they can tolerate traditional hemodialysis, which causes major fluid shifts. So this is a very slow process where blood is removed from the body, circulated through the machine, and put back into the body. And as nurses caring for a patient who is on CRRT, you're going to be caring for them on a one-to-one basis. You're going to have one patient only because they're very sick. And at any given time, there's almost a unit of blood that is circulating through that machine. So if they experience a sudden drop in blood pressure, or if they code, you have to rapidly give their blood back. If they start to have clots in the system, we have to address that because those clots obviously can't be put back into the body. So there are many different things to consider with CRRT. It requires specialized training and one-to-one care in the ICU. So our general approach to acute kidney injury is that we're going to do diagnostic testing. We're going to try to figure out, do we have a pre-renal, an intrarenal, or a post-renal scenario on our hands? We're going to work quickly to identify what is the cause and treat that cause. In identifying the cause and starting the treatment, we're going to make sure that we address any nephrotoxic medications that the person might be on and adjust those doses accordingly, or stop the medications if we need to. Monitor fluid and electrolytes very carefully, paying particular attention to the sodium and the potassium and the phosphorus. And the sodium and potassium, both of those things we know, can kill a patient if they're out of whack severely. So those lab values need to be drawn frequently. And when the lab results come back, you need to talk to the doctor right away. In most cases, ICUs will have protocols for replacement of electrolytes and even for managing hyperkalemia. Treat acidosis. Sometimes we use bicarb in the IV, but it's a tricky medication to use. And when you do use IV bicarb, be aware of the fact that bicarb does not play nice with others. So anytime you have bicarb, you typically need to have a dedicated IV line for that, or you're going to find that it will cause major problems with the other medications that it's being administered with, and you can have major complications from that. Indications for dialysis need to be recognized, and then if we're going to decide to do dialysis, we need to decide fairly quickly to do it, and then decide, is the patient stable enough for traditional hemodialysis, or do we need to go to a CRRT where it's a much slower and more stable process by which to manage the waste, the fluids, the acid base, and the electrolytes. So there's your summary. I hope you've learned something new today. We got some happy kidneys to end the show with. And if you have any questions, please feel free to send me any and all questions that you have via email. Give me a call. You know how to reach me, carla.fry, carla.fry @cfk.edu. Thanks, guys.